Hey, how are you, friends? We had a lot of good sessions. If you have not seen all my previous videos on the Examiner Reckoner series in urology, I will send you this link, the I button. It will be somewhere over here. Right. Today we're going to talk about two very important surgical treatment protocols for kidney stones. They come as a short note and they come as your exam viva questions. And this video is also meant for people who who are not medical students, the focus of our discussion today, but they suffer from kidney stones and also want to know something about what are the treatment options do they have if they have a kidney stone, if any of their family members are suffering from kidney stones. Okay, so without wasting much time, let me share the screen for you. So this is basically we're talking about two important things. We're talking about ESWL, extracorporeal shock lithotripsy, and PCNL, the percutaneous nephrolithotripsy. Okay, this is the two methods. Extracorporeal obviously means that you use energy sources from outside, do nothing inside the body, while a percutaneous make a small incision in the skin and use all your instruments to break the stone within the kidney. Now, what is ESWL? ESWL basically focuses shock waves which are being created by an energy generator outside our body. It focuses that energy in a very coherent method so that the energy source is not lost through their transport, and they just break the stones at the site of the focus. Okay, these are basically sound waves. So any stones less than 1 centimeter, very good. More than 1.5, okay, not obviously beyond 2 centimeter. Okay, and very small stones. Ureteric stones are a very controversial issue because ureteral stones means a stone has been stuck in the ureter, cause lots of edema, and there's some of obstruction. So you don't use ESWL in obstructed system, in infected system. Patients on antiplatelets, you cannot stop the antiplatelet because he has the cardiac stents put in recently. Biodegradable, all these metallic stents and drug-eluting stents, you cannot put them, suddenly you cannot stop them. And also if the patient is a pregnant female, okay, because any form of shock energy is not good for the fetus. Now, very important is aortic aneurysm. A person has an abdominal aortic aneurysms, never person must not undergo ESWLs. Okay, many a times I've seen in my patients done some other issue, gas problem, something else, and they turn out to be abdominal aortic aneurysms. So very common in elderly gentlemen. Okay, now I want to tell you is that it was first discovered by a person known as Claude Dornier. He is basically a German engineer, nothing to do with our medical science. He used this Dornier, this shockwave, ESW shockwave lithotripsy technology to test the supersonic aircrafts used during the world wars. Okay, he's basically interested in supersonic aircraft, nothing to do with urology, but it was only James Lingerman in 1980 who used this concept of shockwave lithotripsy and made it useful to break the stones, kidney stones. Now, other than kidney stones, you can also use to break pancreatic stones and gallstones. Okay, but the major focus is on kidney stones. Now, before 1980, we had to cut to stone, means you have to do an open surgery for stone disease. But beyond this change in the paradigm occurred in 1980 when we had this ESWL in our hand. Now, how does ESWL break stones? The efficacy, it's able to pulverize, just get it in dust. The stone is being brought to dust. How? Because shock waves are generated by a generator. Then they're focused onto a point. They pass through a transport channel which goes through water, which goes through a soft tissue in our body. Then they're focused by focusing mechanisms onto the stone. The stone is basically floating into the urine of the pelvis. Okay, there's a kidney. Okay, I will show you. I will show you in a picture. Just hold on. Just hold on, because many of you may not be medical students. Maybe my community members. What really happens is this is the kidney, this is the pelvis, and it contains the urine, and the stone floats over here. So the focus is over here. Not this. I'm sorry about this. Not this. It basically comes. Let me use the eraser. Okay. It comes from outside. It comes from over here. So it comes from here. So it comes from here and comes at this stone interface. So what happens in the stone interface is, there is a change in the density of the transported environment to which the energy passes. And because of this causes what is known as compressive energy generation. The force basically goes into compression forces, stress forces. It's called as stress forces, and cause micro cracks within the stone, because stone also has some fluid component as well. Now the force goes to the stone, comes to the other wall of the stone. Again, there is fluid component because the stone is floating in the fluid. Okay, so now there is again a change in the consistency, the change in the density of the transport medium. Now the energy, what will do, it will create a U-turn and again come back and hit the posterior wall of the stone, the other wall of the stone, now by tensile energy. So again, it causes micro cracks. Okay, now there's something else again. Now there are three types of generator. We have the electrohydraulic, that was done by James Lingemann, where he put the water patient in the immersed in the bathtub, and the water is around here like a coupling media, and just generate bang that whole system with your sound energy. Nowadays, it's totally they're totally being focused. Everything is focused. All these instruments are basically advanced instruments. What it does is you put a focal point on the stone. Okay, create it with an ultrasound. Do it in a C-arm guidance. You see, that is my focal point, that is my bullseye, and I will send the energy sources up to that source, to that point. Okay, and at that point, the shock wave comes, creates a bubble. It's nothing but a water bubble. What is the fate of any bubble? It bursts, and whenever it bursts, it sends out shock energies and cause micro cracks. So there are three ways stone gets broken by these shocks, and the shocks comes repetitively. Okay, the repetition of this process cause pulverized dust, because we give 3,000 shocks in one sitting. When one shot comes, all this bit creates another shot comes in immediately. Now, what are the components? Obviously, we have a shock wave generator somewhere over here. Shock waves are being produced. A focusing system is also near, where you focus it, channelize the engine, the sources, on the energy sources. A coupling system is something like this. Okay, now this is the generator, three types of generator: electrohydraulic generator, piezoelectric generator, and the electromagnetic, the recent ones. The problem with the recent ones, electromagnetic generator, is they're too focused. And with the problem, the too focused minds is, with a respiration or with some amount of movement, the focusing is lost. The stone overshoots. I mean, the shock waves overshoots the stone, or it misses the target because they're too focused. Less amount of collateral damage, but again, more retreatments. Okay, because the focus is lost, the target is lost by repetitive shocks. Focusing system, I say, this is the focus, is something called the F1, F2, geometrical patterns, ellipsoid, ellipticals, okay, target path, blast path, theoretical stuff. So this is the coupling. So I said the shock waves doesn't go well through the air. If it goes through the air, the energy is lost. So you have to create a channel, a tunnel, or a pathway where there's no much of change the density of the pathway. Fluid, soft tissue, stone. No bones, no hard substances, no air. This is the silicon. This is a silicon encased water cushion that maintains. That is the coupling system. So you put some lignocaine jelly, it very well coapts. You can see it's very well coapts. This is, we do an ultrasound first, do it a C-arm, you see the stone over here, you see the stone, the acoustic shadow, and blast it. Right. This is how it coapts. You can see this is not an ordinary table. There's some breaks over here. You remove this substance, remove this C curve, and you put the whole thing, the coupling system comes with the machine, with the electromagnetic generator. It comes and fits easily to the body. Okay, this is how it fits easily to the body. Okay, so it does the local anesthesia. Okay, and just blast the stone. That's as simple as that. Non-invasive, safe, no anesthesia, short treatment time, convenience. Patient walks off home. He does the work. He does the normal work he used to do. But again, repeat procedures because of target loss, complications like pain. Some patients can have bleeding if they are basically large amount of being repetitive shocks being given. Now, what are the factors affecting stone fragmentation on ESWL? One is size, a bigger stone, no. Okay. If a large stone burden, you have to pre-stent, or else the fragments will come and obstruct the ureter. The patient goes in ureteral colic. At the dead of the night is known as the Steinstrasse or the stone street. Emergency surgery. Post a very uneventful ESWL. Stone composition, that's very important. Calcium oxide dihydrate, the yellow soft stones we see when we are doing a uteronoscopy. Also make the patient see, okay, this is your stone, my dear friend. Black hard stones, calcium oxide monohydrate. Uric acid, dust stones. They're easy to break. These are not easy to break. Okay, and it all depends upon the Hounsfield unit. Stone you see on a CT scan, more than 1,000. Less than 850 versus more than 1,000. ESW does very well. ESW doesn't do very well. Okay. Stone location. Most of the stones are the lower pole calyx. That is anti-gravity. Again, what is a lower pole calyx, my dear friend? People who are from the community, who are not medical doctors, I have this tip for you. This is the lower pole calyx. Okay, this is a lower pole calyx. So suppose I draw a picture like this. Suppose it looks like this. Okay. Now you can understand. This stone is located in your kidney in the lower pole, and this has to be broken by a shock wave. It goes into dust, but have to go upstairs, anti-gravity, and then it has to go down. So lot of paths it has to go. If the gate is narrow, suppose the gate is narrow, if this is long like this, all these are bad factors. So lower pole calyx don't do good with in ESWLs. If you have these things, long infundibular, long length, short wide, and any infundibular stenosis, calycial diverticular stone. Many patients have diverticular stones, have pain due to some other reason, come back, make a ruckus that you have to remove the stone. Very difficult. You have to do PCNL in these cases. Mini percs and ureteral stones. Now this is PCNL, my dear friends. This is a big surgery, very good surgery to make the patient stone free in a single setting. But again, it depends upon different patient characteristics, patients and surgeons' expertise, and the place you are walking in. Also, the stone characteristics. What is the location of the stone? Now, as you can understand, this is the kidney arteries, the renal arteries, anterior and the posterior branches are basically end arteries. The place where they don't join, is known as the watershed area. Okay, where there is no artery, this is no man's land, no artery land on the surface of the kidney, which is not bang in the posterior surface, some slightly on the posterior surface, leaning on the posterior, it's called the Brodell's line, and through which we have the posterior calyces which point over there. These are the calyces. These are the fornix. These are the calyces. This is the tip of the papilla. This is the fornix, the tip of the papilla. So you go through this. You go through this. So go to the skin. Go to the soft tissue. Go to thoracolumbar fascia. Go to genotarsus fascia. Go to capsule. Go to renal parenchyma, and it then enter through the calyx tip, the papilla. You indent the papilla, go inside, go into the calyx, go into the pelvis. Okay, so any form of overshooting up, down, either on side, you will hit an artery, you will hit a vein, and will cause torrential hemorrhage. So you have to be target wise. You have to go through the target, and the target, you don't have your eyes to see. You will have the C-arms to see. It will act as your eyes. Or if you do an ultrasound guided puncture, the ultrasound picture will tell you where to put the puncture. That's when you do a successful puncture, 70% of the job is done. Okay, so you have to check the posterior calyx, straightest path, use a direct calyx. So it was the first time, and Johansson was the first people in 1976 do a nephrostomy track for the first time. So if you have an infected system, put a nephrostomy, come back later. Let the infection heal. Okay, let the patient stabilize. Anterior calyx are difficult to puncture, and if you actually puncture the anterior calyx, it will be very difficult to negotiate into the pelvis. So better the posterior calyx. Puncture the stone axis, and whichever with the straightest part across the stone axis. Obviously, this is the straightest part. So the upper calyx puncture will be better to remove the upper calyx load, the pelvic load, and the also can go and take the mid-level lower calyx. Though may use satellite punctures as well. Opacifying the system. So first and foremost, patient under anesthesia, lithotomy position, cystoscopy, put in the ureteric catheter, opacify the system, prone the patient, make the patient prone and puncture. There's something called the supine PCNL. Sometime we will talk about it. Okay. So what we do the position. So this basically X. We know the Cartesian system. When we are doing on the C-arm, we're not talking about ultrasound. C-arm, basically we think about the XYZ system. The y-axis is the patient lying prone. Okay. The x-axis is, this is a surgeon. This is a stone side. Obviously, the surgeon stands on the stone side and it looks diagonal in the fluoro. Diagonal in the fluoro. This is the x-axis. This is the way forward. While the z-axis is the three-dimensional axis. This is how you move the C-arm and see on a 0 degree, 30 degree, which angle to puncture, the site of puncture, and the angulation of the needle, so it doesn't overshoot, doesn't become superficial, goes right inside that is the doesn't overshoot, doesn't become superficial, goes right at the kidney and hit the stone. So this is done by 30 degrees, 0 degrees, 30 degrees, 0 degrees alternatively. One is the bullseye technique, where basically 30 degrees is over the broadest bloodline split. Now that is the site of the calyx entry papilla. You just see through it. I say the bullseye. It's like the target. You just see the target right down. Okay, you go inside the needle and you see the direction. You see the direction, whether it's overshooting or not, by coming back to 0 degree. Again, there's a triangulation method. Some amount you can go through the different techniques. There's something called the gradually descending method. The triangulation method, you see on the 0 degree and you manipulate and come to 30 degree, come and manipulate the needle. So it goes to a straight tract, doesn't go here, shortest tract, straight tract, and you see the depth also. The z-axis is also maintained. Okay. So this is the lower port. What you do, put in the guide wire. After you do a successful puncture, see the egress of the urine and dilate the tract. There's alkanes metal dilators, there's silicone dilators as well. There's ampullus dilators as well. So what's the best thing is alkanes telescopic dilators, because one goes above the other and tamponades. You don't have to remove it. There's bleeding and then you have to move it again. So it actually auto tamponades your tract. And then you put a nephroscope and go inside, break the stone, come out, put a nephrostomy tube. And the job is done. So complications to end with is bleeding is very important, because most of the patients bleed. Most of the venous bleed, they stop by themselves by tamponade, but some require. So it's better to have a blood in hand, because 15% there's a rate of blood transfusion. Less the severe acute bleeding, less than 5%, which may require angioembolization. Perforation in the collective system is there, and upper polar punctures will have this lung injuries, thoracic injury, pleural injuries, which will require thoracocentesis, putting in a chest tube. Seeing on a post-op, it's supposed to have this after you come back from anesthesia. You see that the patient is not able to take breaths properly. You see that there's a fluid in the C-arm also. You see there's a fluid in the thorax, the hemithorax. They put in a chest tube in these cases. And additional organ injury, sepsis is very common. Infection, patients will have transient fever, 30% cases, but or 5% will have severe sepsis. And additional organ injury, very common, is chronic injury, where you actually have to retract the nephrostomy. Actually, nephrostomy goes to the colon and into the kidney. Retract it from and retract the colostomy, and retract the nephrostomy, make it as a colostomy, and put in a digestion and come out and treat the patient conservatively with IV and alimentation diet and all these things. So this is all about PCNL, ESWL. Hope you like the lecture. And if you have any question, then feel free to write, send me a mail. I've given my mail ID somewhere around here. And also, if you have not gone to my web pages, I've sent the links of our web pages, and also go to my library section of my drprobirbasu.com, where we'll have lots of these video lessons over there. Okay, so bye-bye. I will come back with another important lessons very shortly. Thank you. Okay, wait a minute. Let me stop.